welcome back to the Venous and Lymphatic Forum. We are broadcasting live from the DEBAKEY CV Live studios in Houston, Texas at Houston Methodist Hospital. I am Ulises Baltazar. I am your host. I'm sorry about the disturbance. Traffic was awful, just made it, but we are going to be okay. So today we're going to have an interesting talk about chronic venous obstruction. But before we jump into this, let me remind you that if you have any questions, comments about this presentation, you may be able to communicate with us through those platforms that are in your screen right now. That way we can answer in the best possible way your questions, and it's a learning experience to all of us. So feel free to do that, and again, we'll try to help as much as we can. Today we are honored to have Dr. Joann Lohr. She is a board-certified vascular surgeon, and she is the chief of vascular surgery at Dorn VA in Columbia, South Carolina. She has vast experience treating vein disease, especially chronic venous obstruction of the venous system. So today, Joann is going to talk to us about the catheter-based interventions for chronic venous obstruction, and we are so pleased that she could join us and let us learn from her vast experience in this topic. Welcome, Dr. Lohr.
Thank you so much for the invitation and the privilege of being here. I hope that you can find some useful tips and tricks in this talk. I have nothing to disclose. And give me a second here. Yeah. My slides aren't advancing.
That's okay.
But we'll get them.
That's okay.
There we go. There you go. I have nothing to disclose, and this is the enemy of what we're looking at. Okay, this is very prevalent. If all of these that treat arterial disease, venous disease is 6 times more prevalent, and causes a lot of days lost work and disability. Thanks. Venous pressure in the leg is determined by 2 components: the hydrostatic component, which is the weight of the blood from the heart to the foot, or the hydrodynamic component, which is related to the pressures generated when you walk, when the skeletal muscles in the leg and the capillary network. The standing pressure in the leg is mainly hydrostatic at 80 to 90 millimeters, and when we walk, it drops down in a normal person to 30 millimeters. Air plethysmography is one of the ways that we can diagnose the amount of reflux, and the amount of reflux is important in predicting outcomes for our interventions. And again, normal is less than 10 mLs per second. Severe is greater than 10 mLs per second. The ejection fraction looks at your calf muscle pump function and the efficiency of the muscle pump to function. Normally, the ejection fraction is greater than 60%. So Julianne Stoughton in the most recent In Vein magazine was asked the question about what do you do with deep vein reflux and superficial ablation when you have reflux in all areas. Bill Marston has authored a paper that says when you have a high femoral vein reflux velocity greater than 10 centimeters per second, and you see less clinical improvement after endovascular ablation of the superficial system by itself. So you need to really maximize all your conservative measures. Consider valve repair, grant transposition, or substitutes, but by an experienced team if you have good landing zones. The classic Thurner Syndrome, as everybody knows, is the left common iliac vein compressed by the right common iliac artery. And here's basically what you might see. And here's with the overlay what you also could see and how this puts together. Chronic non-thrombotic stenosis, you see flow collaterals, but you have a patent lumen. It's easy to get a wire up, and these people do very well. Remember that 30% of women with chronic pelvic pain have some form of pelvic venous congestion. Pelvic venous reflux should be considered also in men with varicose veins and recurrent varicose veins, or with varicoceles. And the testicular vein and internal iliac vein reflux can be a source of these problems. Those can all be treated with embolization. This is an old slide from Dr. Brau's textbook, and it basically gives you the collaterals and the connections of the pelvic circulation. And when you see patients and you see cross-filling of the pelvis, you need to think that there's an obstruction proximally. You can see different degrees of obstruction and different degrees of collateralization. Some of these people, when you test them and they have this kind of collaterals, they'll test almost normal. Iliac vein compression has a prevalence of almost 15%. When we try to treat it with endovascular treatment, we're very successful at 96%. We really don't have much difference in treatment and success as far as post-thrombotic and non-thrombotic patencies at 1 year. Edema relief is much better for thrombotic than it is for non-thrombotic patients. And the cumulative ulcer healing rate is almost a little over 70% at 12 months if you follow these people out. Recent article that just came out in the Journal of Vascular Surgery, Venous and Lymphatic Disorders, the May issue. There was an international working group that put together the equivalent of SEEP, but for symptoms of varicosities and pathophysiology, and came up with a nomenclature for pelvic venous disorders. I would encourage all of you to read this. The next series of slides are going to come from that article. Basically, they divided the anatomy into 3 zones in the abdomen, and then the 4th zone includes the lower extremities and the deep and superficial veins. Zone 1 is the left renal vein. Zone 2 is the gonadal, internal iliacs, and pelvic venous plexus. And zone 3 is the pelvic origin of the extrapelvic veins. And there's a very good article. There's also going to be a workbook to come out to help everybody learn how to use this. So if you're treating venous disease, I highly encourage you to look at this. This slide A is a compression of the left renal vein at the white arrow over the crossing of the abdominal aorta. Slide B to the right shows the venographic contrast attenuation where the vein crosses over the aorta, and that's the black arrow. There are renal hilar varicosities at the white arrow, and ascending collaterals are at the dashed white line. This the slide A is a chronic pelvic pain patient that had compression of the left renal vein with secondary reflux in the left ovarian vein. The selective venography shows compression and obstruction of the central left renal vein, and that's at this black arrow. The renal vein is draining through the renal trunk. And then the slide B is the left ovarian venography with pelvic varices and myometrial varices. That's that red star you see. And then there's a bunch of small other little arcuate veins as well. We don't really think a lot about all these pelvic collaterals and crossing, but they're really important if you're starting to think about central venous obstructions. The slide on the left here, slide 1, shows the left flank pain patient with chronic microscopic hematuria and pelvic pain. And there's a AVM in the inferior pole of the kidney, and this drains to the left ovarian vein. The pelvic varicosities are also shown on slide 2 here. The next one shows a bilateral primary ovarian vein reflux with left ovarian vein where the black arrow is, and then multiple pelvic varicosities shown by the white arrow. The slide on the right shows the left common iliac vein compression, and this is one we're all used to seeing with contrast attenuation at the arterial crossing. That's your black arrow, and then the left iliac vein reflux is the white arrow. The slide on your left shows symptomatic vulvar varicosities in the pelvis causing pain from bilateral ovarian and internal iliac vein reflux. And then there's reflux through the external pudendals as well. Slide on the right shows post-thrombotic venous claudication. Is a patient that complains of post-thrombotic venous claudication and left lower extremity swelling, but there's no visible extremity varicosities. This patient had post-thrombotic changes in the left common and external iliac veins, and those are your black arrows, and then had large obturator collaterals draining into the internal iliac vein, and that's your white arrow. This is one that can be a little confusing because this patient has painful recurrent veins in the left medial thigh varicosities, but the origin comes from the pelvis, and this is over the medial thigh compartment with the pudendal and the inguinal tributaries that are draining from the left, the external iliac vein. So May Thurner is iliac vein compression was first described by Virchow in 1851. He has described it as chronic external irritation with chronic repetitive compression of the left iliac vein by weight and or the common femoral vein. May and Thurner described in 1957 the lesions that were found commonly in the iliac vein. And in 1965, Cockett and Thomas described the left iliac vein compression in both symptomatic and asymptomatic patients. You can have an acute phase where they have sudden onset of swelling, commonly seen after surgery and immobility, or you can have more chronic phase, which is what we're really going to talk about more this evening, with claudication, extremity pain, swelling, and stasis change and ulcerations. Again, the suspected unilateral venous changes on the left side with negative venous ultrasound, you need to think about this. And you need to think about alternative imaging, not just looking at the baseline, but you also need to look at some of the subtle clues on some of our imaging that's also overlooked. IVUS has been a very useful guide for diagnosis and treatment. Iliac vein stenting is effective with patency at 90% up to 5 years, and non-thrombotic lesions have better success rates than thrombotic lesions. So it's not just about the reflux. We have a relatively poor understanding of venous outflow obstruction and the pathophysiology, both primary and secondary chronic venous disease. Until the last 5 to 10 years, this had not gotten much interest. And that was due to the sole reliance of the Doppler and the duplex to diagnose the lower venous system. It's unknown what percentage of blockage or narrowing when the venous stenosis becomes critical. We have not had real accurate, non-invasive, invasive testing until recently. And even then, the occlusive and non-occlusive obstruction is arbitrarily defined as 50% stenosis is considered as significant based on your outcomes. You want to look at your Doppler flow. Instead of having spontaneous and phasic flow, this shows a continuous waveform and is suspicious for more proximal obstruction. You want to look for respiratory variation and augmentation. On the CAT scans and other imagings and the femoral vein sizes, you need to compare the waveforms and the vein sizes. And there's been some association with vein size and the prediction of DVTs. There is also a lot of right iliac vein compression that can be found on CAT scan. Trying to figure out when it's significant or not is a problem. And the iliac vein diameters can actually predict the success of your catheter-directed thrombolysis in those that have iliac vein compression. So here you can see a CAT scan with the asymmetric veins. The right's much larger than the left. IVUS again is critical. The venograms will underestimate the degree of stenosis by 30%. And you can have it accurately measured and much more appropriate, because you don't see frequently the synechia and some of the webbing when on without IVUS. You can select your stent and the length of the stent. You can make sure you're covering the entire lesion when you're placing stents, and it help with your long-term stent patency. And you want to make sure you have good endpoints for landing of your stent. And there's good stent apposition, so you avoid any recoil or you treat it when you see it. This is a CAT scan that if you look at it and you're looking for bowel obstruction or something else, you may miss it. But this patient has very large lumbar collaterals. And if you look up above the cava, it's occluded or atretic. Sometimes you'll see a lot of filling in the azygous and hemiazygous veins. And sometimes you'll see on venograms, you'll see systemic to portal shunts. This was a young man who was missing his part of his subhepatic cava and had very brisk flow to his liver through his SMV. Excuse me. In younger patients, you want to always think about congenital developmental anomalies. It's frequently misdiagnosed and overlooked because we don't look at the central circulation. And again, duplex is not completely adequate in evaluating this. Remember, the normal development of the inferior vena cava is a complex series of anastomosis and regression from embryonic remnants. The inferior vena cava has 4 segments to it: the hepatic, suprarenal, renal, and infrarenal. The subhepatic is the most commonly observed place for an anomaly. Congenital anomalies of the vena cava are reported, and they often are not picked up until adult life, when the patient has a DVT or has a venous insufficiency or a mass that nobody understands. They tend to be underdiagnosed, and Timmers and his group have estimated that up to 0.3% of congenital anomalies are the result of intrahepatic interruption of the general, compared to the general population. Agenesis results from the continuation of the systemic circulation, and that's where you see the hemiazygous and azygous veins with the direct communication to the hepatic vein in the atrium. Again, the series of inferior vena cava and renal anomalies that you see. Recently, we had a pregnant, 26-week-old pregnant, 26 gestation pregnant lady with twins, who I got a call from the OBs saying something wrong. Her right leg is so swollen, but they don't say there's any clot on it, and they said an ultrasound's normal. Well, here's her left common femoral vein, and it looks pretty good. The right common femoral vein, however, doesn't look so great. And then you look at it even more, and it's got an obstructive waveform. Because of her gestation, we got an MRV, and she actually has a complete left-sided vena cava. And where she crossed over on the right, the pregnant uterus was compressing the iliac vein. She did not have thrombus, but she had outflow obstruction. So as a reminder, young patients and people with atypical presentations always think about congenital anomalies, and you need to not only work them up for thrombophilias, but also look them up for developmental abnormalities, and be aware that they are very, very complex, and the venous system is one of the most varied systems in the whole body. Treatment is usually conservative, and it may require anticoagulation for life and compression. If you have patients that come in and they're thrombosed, who should you lyse? The blast tool, I think, gives you a lot of food for thought. You assess the bleeding risk, the life expectancy, which should be at least over a year, anatomy of the clot and its extent before you start to lyse it. If it's located in the cava and iliac vessels, that's a good choice for lytic therapy. The recent trial that was completed didn't show benefit because there were a lot of popliteal and femoral veins included in it. So the C-track trial is reevaluating some of that. The severity of the DVT, and then if the symptoms and the signs have been present for more than 21 days, you may want to reconsider your choices. This is a young lady of mine who I treated in 2004 with an acute DVT. You can see here she presented, and then we lysed her open. She did well. She had a stent placed. She was initially treated with anticoagulants and then stopped. 6 years later, she was having more swelling, and we restudied her, and she had some in-stent restenosis that we treated. Sorry, I'll go back one, and we got everything open, widely patent. And this was her 15 years after her initial thrombotic episode and her initial treatment. So if you didn't know she had something done, you really would be hard-pressed to know there was any difference here. Sometimes you'll see the IMV is really large, and you see that on imaging studies. Sometimes patients will present with bleeding from the rectum, and you could see a lot of pelvic collaterals. This is a patient who has an occluded filter and has had rectal bleeding, was seen in the emergency room, and they were going to do a hemorrhoidectomy, and they kind of rethought that. And again, if you have atresia, you can see a lot of collaterals in a lot of different places. We don't always know what happens when we take filters in and out. This is a gentleman who had a filter taken out 4 years earlier, came into the ICU and could not be anticoagulated, and they wanted us to put another filter back in, and his cava has actually been obliterated from his first filter. And so you can see here, my talk on this one is gone but not forgotten. Even though they've had temporary filters in and out, you always want to double check what's going on and really consider caval occlusions. This is what I call the ouchie wawa picture. This is a young nurse who's in her 3rd pregnancy and developed varicosities. She has vulvar hemorrhoidal varicosities, medial thigh varicosities, was quite miserable. And after she delivered and we stented her, she had basically normal anatomy. So venous stenting is very safe and effective at taking care of pain, reducing swelling, and healing ulcers. It definitely can improve quality of life in patients with primary as well as post-thrombotic vein iliac obstructions. Patency rates are better for non-thrombotic than thrombotic events. The anticoagulants and platelet treatment post-therapy we can talk about a little later, but it's controversial. And usually a combination of therapies is what's being treated, but we don't have any good real evidence and hard data. So again, the IVUS is critical because your conventional angiography is not reliable to completely identify venous outflow obstruction. IVUS will help you with your collateral filling and identifying release points. It'll help you with the degree of residual stenosis, the interluminal fibrotic trabeculiations, and then stenting is should be considered in those with a greater than 50% luminal reduction on IVUS. And remember that the lesions in the veins are different than the lesions in the arteries. They have a lot more elasticity and recoil and much less calcium, so they don't crack open and stay open. Things that are associated with stent patency in iliac vein treatment is the adequacy of the inflow. So you must have a good femoral vein or profundifemoral vein. Sometimes we'll actually consider, much like we did when we did the De Palmer operation, we would add a stent to this to increase flow if we need to through a fistula, at least temporarily, to maintain patency when we're doing some reconstructions. You want to look at your stent characteristics, and these are different. They have a diameter that's bigger than the arterial stents. They need to resist extrinsic compression. They need to extend up into the inferior vena cava. You have to cover all the disease, and you need to make sure you have good wall apposition. Again, radial force and flexibility are the key to venous stents, as well as the bigger size and lengths. Stents right now are undergoing a huge evolution, just like 15 or 20 years ago, there were so many aortic stent grafts, and therapeutic revolution for aneurysms was taking place. These are just some of the stents that have been out and have been used. When we didn't have the dedicated venous stents, we're using wall stents. The different configurations of the wall and the design of the stents are all over the place, and this just gives you some of the examples. In the recent JVS article, again, there's an article that talks about that the braided stent with a wires loop back and forth, which is the one on the left, may be more resistant to compression if we're extending down to the external inguinal and the inguinal ligament. So you may want to really consider where you're placing your stent in your stent selection. The FDA stent platforms that are approved are all self-expanding, non-braided nitinol. The stent matrix for the most part is closed layout with Vichy, but the others are all open cell networks. Sizing still can be a bit of a problem, although this has gotten better. Double burst stenting is to be avoided, and there's some new stents in process that are much like the aortic stent grafts, where you have a body and a limb, and then you put the other limb in, because when you do the kissing stent technique, you can get competing flow, you get compression of one side or the other, and you don't have good apposition, and in the gutters you can get increased risk of thrombosis. Braided nitinol stents, again, might be less prone to fracture or occlusion at the inguinal ligament when they compare to that laser nitinol stents. That's data out of Europe that's not been reproduced here yet. Again, stent diameters, the inferior vena cava, 24 millimeters, common iliac, 16 to 18, and the femoral 12 to 14. You can pick this with your IVUS assistance. But remember, not everything that's gold is gold. The FDA has a class 1 recall of some of the venous stents currently. Now, the Boston Scientific, the Vichy, SDR, and RDS have been prone to migration and movement, and Bard, the Veno Vivo, has had some stent collapses. So really think about what you're putting in and where you're putting it in. The venous stents, again, have to conform to the shape of the vein. They have to move with a changing diameter of the pelvis without kinking or causing a significant decrease in the cross-sectional area. They have to have a radial force that is outward and resist the peripheral tissue, the surrounding tissues from the inward pressure. They have to be crush resistant. They have to have some hoop strengths and how much circumferential load they can resist. And they have to help us overcome the elastic recoil of the interluminal webs and the intramural fibrotic lesions. They have to have a long durability and a deployment accuracy, especially when you're placing these in young people. So the venous stent, again, IVUS is critical. Angioplasty alone is not usually significant and sufficient enough because of the elasticity and the recoil in the vein walls. In-stent restenosis should be suspected when patients develop recurrent symptoms, but in the acute phase, it's fairly unusual. Endovascular treatment is usually successful about 97% of the time. All treatments in this study were done with percutaneous angioplasty and stent placement. They didn't have any severe procedural related complications. And they had cumulative 1, 3, and 5-year primary patency rates at 34 months follow-up of 93, 84, and 75%. Independent predictors for in-stent obstruction were the use of multiple stents and then the patients that were not compliant with their compression. The Mayo Clinic primary assisted patency rates at 1 and 3 years are 94 and 90%, and secondary patency rate of 95. So we do quite well with this. This is a patient who had a stent placed and obviously has now occluded it. And so we need to get this reopened. There was a filter above, and the filter was patent. We were able to get a wire up and get a stent up, and then stented against and past the filter to help maintain that. Remember the hemorrhoidal varicosities. Anybody who's had venous thrombi or filters, you need to really double check what's going on with their venous circulation before you get into things. Otherwise, it's like operating on somebody with portal hypertension, but in reverse. And again, the inferior mesenteric varicosities in that lady I showed you earlier. If somebody did a hemorrhoidectomy, and I'm afraid she might not have survived. So another lady who presented with a occluded filter. We were able to lyse this open, and then we basically put the stent up against the filter to kind of crush the filter back, locked it against the wall, and the patient did very well and had good flow through there. So iliofemoral stenting for lower extremity stasis symptoms gets excellent results, and this is a paper that looked at 56 limbs at 3 months. Patients all had ulcers that hadn't healed at 3 months. They then went to venography and IVUS. And they had a greater than 50% reduction in their cross-sectional area. 18% were post-thrombotic. Some had incompetent perforators or superficial system issues, and 52% had deep reflux. 29 of these 56 limbs needed stents for stenotic lesions, and 58% of the stented group had healed their ulcers in 1 week to 8 months. So you could see some rather dramatic results with stenting when it's done for the right reasons. Again, predictors of in-stent recurrent stenosis. Severe in-stent stenosis, again, is very uncommon in the early phase. The risks for this are previous thrombotic disease, positive thrombophilic test, stent length extending below the inguinal ligament, and the non-compliance with stockings. So where are we now with regarding the stenting and post-thrombotic syndrome? The evidence is weak. The grade assessment of the quality evidence is very low, and this comes from looking at 11 relevant outcomes. We have high technical success at 95%. The 30-day thrombotic rate was 3 to 4%. Venous injury occurs in 18%, back pain in 52%, edema relief in only 40%. I'll come back to that in a minute. Ulcer healing at 75%, and pain relief at greater than 50%. So this is viewed as a low-risk procedure with low quality of evidence, but potentially very effective. And again, primary assisted and secondary patency rates at 12 to 36 months are quite good, between 80 and 90%. So the hemodynamic impact of venous and caval stenting is that it eliminates venous claudication, it normalizes your outflow, it can enhance the calf muscle pump function, give you significant improvement in the venous stasis and ulcers, increase the amount of reflux needs that they really need to be in their stockings, and it's quite pivotal to your outcomes. And you want to allow recovery of the microvascular dysfunction at different levels with decreased venous pressures to occur. And you can actually see some of the skin changes, and some of that thick lipodermatosclerosis will regress over time. So what about the old people? Because all my people are heavy and out of shape and sit a lot in 80s and 90s, 70s, 80s, and 90s. Can we do this in octogenarians and older? This study looked at 192 patients greater than 80 years with venography and IVUS and stent placement. Again, treating lesions greater than 50% cross-sectional area reduction. The overall improvement in pain, edema, and ulcers was 59% in octogenarians and 65% in non-octogenarians. They had no surgical site infections, no pseudoaneurysms, and no AV fistulas, and no femoral artery injuries. They also required no transfusions and had no 30-day mortality. So if your venous patients are like mine and they complain a lot and are very unhappy with being told there's not much to do, this is something they can do, and in carefully selected patients is quite effective. So what about leg swelling? Swelling is one that I'd give you a word of caution about, because patients who have endovenous closure and iliac stent placement, this study looked at 173 patients. They found no correlation with age, gender, presenting symptoms, the use of calcium channel blockers, nitroglycerin, Plavix, aspirin, Synthroid, Coumadin, angiotensin, beta blockers, and all of these things that are listed here. There was no difference between radiofrequency and RFA. Use of Lasix was associated with persistent swelling, but the use of two diuretics was significant and predicted likelihood of failure. So if you have people that are complaining of swelling, and especially bilateral swelling, you need to really reconsider what you're doing and analyze it carefully before you start an intervention. So as far as the chronic iliofemoral and cable thrombotic patients, those with C3 to C6 disease really do well. You can get rid of the venous claudication, normalize their outflow, improve the calf muscle pump function, and heal wounds, as well as get rid of their pain and the dyspareunia. These are some of the most grateful patients you'll have. When you have secondary occlusions of IVC filters, these can be very successfully treated. You can basically extend the filter the stent across the filter. You don't have to try to remove the filters, because some of these filters can't really be gotten out easily percutaneously. All the patients should be anticoagulated. They had 87% improvement in patency, and secondary patency was 100%, even though it's a small study size. But I've had 2 or 3 like this that have done very well. You can consider hybrid procedures with endophlebectomy. You might want to add the arteriovenous fistula creation here. Yeah, this is basically open surgical disobliteration of the scar tissue. Distal extension across the inguinal ligament into the deep femoral vein is important, because you really want to have inflow. Venous bypasses are another option, but all of these address the inflow issue. The Delphi consensus was a survey that was taken of 200 vascular surgeons that did a lot of venous work, looking at how to treat people with anticoagulant therapy. And they looked at and did a survey of what everybody did for the first 6 to 12 months post-stenting. For compressive iliac lesions, they used low molecular weight heparin for a variable period of 2 to 6 weeks. Remember, low molecular weight heparin has a high activity, which is anti-inflammatory, that you don't see with some of the other agents. I would also comment that the patients who had early stent thrombosis on DOACs, we had a much harder time. It was very difficult sometimes to recanalize those. So I've been using the low molecular weight heparin. These patients should be on long-term anticoagulation if they've had multiple DVTs. You can think about stopping anticoagulants at 6 to 12 months. If they've had just a single episode of acute DVT, there really is no agreement on the rate and duration of long-term antiplatelet therapy. Thrombophilia screening should be done before you discontinue anticoagulants in a post-thrombolytic patient, and venous stenting even after the first DVT. And a lot of this is extrapolated from arterial disease and is an area for research that anybody's interested in. Rivaroxaban and vitamin K antagonists following early stent thrombus removal and replacement of stents for acute iliofemoral DVT. This is data extracted from the Swiss Venous Registry. It's an ongoing prospective database, and basically the effectiveness and safety of rivaroxaban and vitamin K antagonist is about the same at 3 months. So again, the post intervention duration of surgery is not well established, but it's not really influenced by the presence of a stent. Anybody who has thrombolysis should be anticoagulated. Acute phase of thrombolysis, irrespective of technique, whether or not stenting is applied, should be treated with immediate anticoagulation if at all possible to reduce your risk of thrombosis recurrence and propagation. So if you look at the patients a little differently, if you look at the non-thrombotic iliac vein lesions, and the thrombotic lesions, procedurally, they're pretty much the same. 5,000 of heparin, and then full dose low molecular weight heparin usually started 4 hours after the procedure, and they're in sequential compression devices with early mobilization, and they stay in those until they're completely mobile. The difference comes when you're in the long-term treatment. The non-thrombotic patients are treated 3 to 6 months after stent implantation, and then duration is considered on a case-by-case basis. The post-thrombotic people, you want to really think about long-term anticoagulation because of the risk of recurrent DVT, the underlying associated with thrombophilic factors. And if you're in the vena cava, you probably want to just tell them they're going to stay on it for the rest of their life unless they have a complication. Antiplatelet therapy, again, controversial, retrospective study, 62 patients followed for just short of a year. Cumulative patency rates, primary and secondary, 70 and 92%. 97% of the patients received anticoagulation initially, and then 61% received antiplatelet prophylaxis with aspirin and clopidogrel and a combination. Regression analysis post-stenting, the antiplatelet use remains significantly associated with primary stent patency. You need to follow their baseline platelet counts, and neutrophil lymphocyte ratio are associated with early but not late stent failure. Again, the lesions are different in that the thrombotic lesion and non-thrombotic lesions have different characteristics. The non-thrombotic lesions have a focal extrinsic compression. They're frequently narrowed but not completely obstructed. They require less extensive interventions. A low rate of post-thrombotic stenosis is noted, 96% patency at 1 year. And then the recommendation after the first 3 months is aspirin and or Plavix alone. Again, the Delphi consensus panel used anticoagulation of variable length of time, and there's no level 1 data. The post-thrombotic patients have a much more complex, extensive process going on. You're recanalizing a chronically occluded outflow tract. There's a longer segment. There's a much larger inflammatory stimulus that you're dealing with, and they have equally high risk of thrombosis or stenosis. The 73% patency rate at 2 years, and this is where I think months of low molecular weight heparin is really helpful because it gets you through that first inflammatory surge that's initiated with all of this manipulation. These patients are all done under general anesthesia because they usually can't hold still and tolerate doing this awake. So let's look at a few unusual cases. Right-sided iliac vein compression is compression between the right common iliac artery and the osteophytes of the lumbar spine. It does happen. Right iliac stent placement can lead to some edema and some resolution of symptoms with compression hose. There again, the left side of vena cava that I showed you earlier. And this case that I'm going to show you now is a 22-year-old college student who got a salmonella infection for pet iguana. And then 2 weeks later came in with what the ER thought was phlegmatia. She got a CTA, and they called and they said, oh, by the way, she doesn't have any problems with her arteries, but her veins are not doing so well. So here's her initial venogram, and you can see that she has, we lysed her, put a stent in her, and we used wall stents because she had a very long, her inferior vena cava distally was quite small, but her right side was really small. And she has done well. You want to always try to figure out what the underlying pathology is in these people. you're not going to get very far if you try to put a stent in this lady. She needed a hysterectomy. She has a complete collapse of her inferior vena cava from compression from a fibroid uterus. She's 38 years old and referred because she was having difficulty getting pregnant. Well, we took out her uterus. We had some concern about what was going on in the cava above this, and we did not put a filter in, but we monitor with TE monitoring and intraoperative cardiac anesthesia type setup. Another young lady that shows up in my clinic, again, she's pregnant, and they said, where did all these veins come from? And she's got them across her abdomen, across her chest, down her legs. Well, she actually had a B-cell lymphoma, and you could see here, thankfully, she delivered a healthy baby. She went through the first 2 cycles of chemo while she was pregnant, and after the first cycle, all those veins went away, so she didn't really need any treatment and had no residual disease. So another group of people that are kind of underdiagnosed and unrecognized is the iliac vein compression in patients who have hip replacement surgery. Again, lots of patients have issues with DVTs, but anticoagulation alone is okay for DVT, but if it's a complicated compression system and issue, you need to figure it out. This is a 83-year-old lady who had a hip replacement, and for 3 or 4 years, her left leg kept getting more and more swollen and wouldn't go down with any treatment. It was quite painful, and here you could see why. So the cement got away, but once we got some of that chiseled out of there, we were able to stent her successfully, and she is still walking. Mr. PP is a guy who had a hip replacement complicated by a hemorrhage. He developed a mass that was a mixture of, ended up being a mixture of cement and old blood, but they at one point thought this was a tumor. He underwent a biopsy here, and then we tried to stent him. We had a lot of trouble. He initially run here. We couldn't get across. The delayed contrast run is here, and ultimately we ended up coming from the neck down and doing this with a snare and getting across that way. We were able to get across successfully, and then we're able to stent him open. He had progressed to venous ulcers and was very appreciative that he could now go back to work. He ran a lumber yard and is back being the supervisor he wanted to be. And here you can see the post angioplasty. He had a lot of extrinsic fibrous tissue we were dealing with, but this has stayed open. Metallosis is maybe a term you don't know. Some of the old metal on metal hips are prone to degradation. They can cause inflammatory changes, cystic and solid masses. Frequently, they're thought of to be inflammatory and infectious. Here on the lower left, you can see the infectious, a big mass there with the arrows outlining it. And then here you can see where the vein is compressed. The artery is okay, but the vein is totally compressed. Particulate disease is another name for this. This is an elderly lady who'd had 2 hip replacements on one side and 1 on the other side, was in a wheelchair with lymphedema, and her big concern is these blue bumps on her lower abdomen, and these were venous collaterals. She actually has an occluded iliac, but to do anything for her, she was fairly debilitated with this and wanted to know she didn't have a cancer. She did not want to have her hip joint re-explored for the 3rd time, so she's in custom compression and doing well. What about the contralateral iliac vein thrombosis after you stent across the caval confluence? This study looked at 376 patients and patients that had non-compliance with their stockings or with their anticoagulation did do very well. That's predictable. Patients who had a preoperative contralateral internal iliac vein thrombosis did less well. And if they had a pre-existing filter or had an acute DVT, they did not do as well. But you could stent across the iliocaval confluence safely and maintain them on anticoagulations and not have too many issues. Again, post-thrombotic patients are more prone to contralateral thrombosis, so you have to make sure you select your patients carefully. Again, you can extend through the inguinal ligament. The braided stainless stents have promise for that and are looking like a good idea as far as stent selection. Patency is not related to the length of the stent or the placement across the ligament, but it's dependent on the underlying etiology and whether you're treating post-thrombotic occlusive disease or non-occlusive disease. Stent placement is through the femoral confluence into the dominant inflow vein, and there are some different stents that they're trying here. So again, be on the lookout for some new developing announcements. one of the things that's come out in the last couple of years is the association with lymphatic disturbances and venous outflow obstruction. This paper looked at 26 limbs that were dilated and stented. 8 were abnormal, and 18 had much improved lymphoscintigraphic studies. And in 1 year, the swelling was improved. Some of them had complete swelling resolution. Pain was decreased significantly. And these, again, are very happy patients. They all had improved quality of life. And you could imagine if you have legs that look like this with a phlebo lymphedema, you're quite miserable and quite immobile. You want to remind yourself that when you're standing, your arterial pressure is 100. When you're laying down, your venous pressure drops to 8. When you're standing, there's a huge increase in your pressure, and it's directly proportional to the height of the column of blood from the heart to your toes. Standing is basically considered a passive hyperemia in the blood capillary ultrafiltration zone. Reabsorption of the fluid does not occur, and walking decreases venous pressure, as we talked about earlier. So this is a presentation Dr. Raju gave at the American Venous Forum. The slide on the left is the pre-treatment patient, and then the slide on the right, you could see how the outflow and the lymphedema almost normalized with iliocaval stenting. So you can imagine what kind of change that would cause in your obstruction. So endovascular recanalization of chronic obstruction can be accomplished with a hydrophilic wire and a catheter most of the time. You don't want to go too close. You want to avoid the common femoral vein access for iliofemoral recanalization and use alternative things further away, the jugular, popliteal, femoral in the upper thigh. Be careful with off-use label of the TIPS needle and transeptal needle and the arterial reentry devices. In challenging cases, they can be used, but they also can have fatal results. There is some hope for radiofrequency wire recanalization. IVUS is important, and don't forget open endophlebectomy is also an option. This is a case, I don't think we think about this at all. And I didn't until this guy showed up. He had a spine surgery, a 40-year-old gentleman who now has a venous ulcer that won't heal. He's 4 years out, and his left leg is very swollen and compared to the right, but he doesn't have any visible thrombus. You can see here the hardware is occluding his vein on this left side. So imagine our surprise when we studied him and he basically obstructed. Not really. The slide on your left will get your attention if you only have one view and you don't have IVUS up, because it looks like, it looks like the screw goes right through the cava. It did not, but there was not much of a lumen here. We were able to recanalize everything, and you could now see the venous stent sitting basically inside of the obstruction. I'm not sure why that's advancing on its own, but and so this gentleman is on lifelong anticoagulation. I think that we don't see patients when vascular surgeons frequently do spine exposures. We mobilize a long length of the vein, and whether it becomes trapped in scar tissue from events around it, or we cause bleeding, or they have a DVT. I think patients that complain of swelling after their spine procedures, we need to consider evaluating for central venous obstruction, because this was a very rewarding case. Patient was so happy. He said initially, I wanted to have my back done so I could work, and now I have had my vein done so I could go back to work 4 years later. Some unusual considerations: the right common iliac artery aneurysms can cause trouble. This is a patient who had basically a presentation of phlegmatia on his left leg. His scan shows he's got an iridobifacial graft, but he developed a common iliac artery aneurysm, and that was completely occluding his left iliac vein. We lysed him open, but we couldn't get the main trunk open. We got the collaterals open, and he got rid of his venous claudication, and his swelling went down. And then only after we fixed and debulked that aneurysm were we able to get the remaining vessel open and then stent. So the current guide to stenting in the placement in context of chronic venous insufficiency. The European and American societies have recommended endovenous stenting for severe obstructive venous disease, but the supporting evidence is weak. American Heart Association gives a weak recommendation. In the 2017 European Society of Vascular Surgery recommends stent placement after percutaneous transluminal venoplasty be considered in those with chronic deep vein obstruction. The C-TRACT trial is underway to try to look at treatment with no endovascular therapy versus stenting. So the clinical presentation of chronic venous patients, you need to suspect that there's a central venous outflow obstruction to go with some of this. You need to look critically at your duplex, your ultrasound, your CTV, and your imaging studies. Remember, look for the subtle signs. If the patient has venous stasis changes, are 18 to 75 and have a life expectancy of at least 12 months, you could consider going further. You want to get biplane venography and IVUS and evaluate things. You can manage them according to the duplex findings and just anticoagulate or treat with compression. Yeah, again, if it's reflux and incompetent superficial system, you may do something else. You also want to be careful to consider scarring in the deep system. In all cases for intervention, we do under general anesthesia. You keep the lower limb intermittent compression device on, the pneumatic compression device on during the surgery and throughout the procedure. They're on bed rest for 4 hours afterwards. They're ambulated, treated with low molecular weight, therapeutic dose heparin at 4 hours post-procedure. A lot of these people have some significant amount of discomfort. They're in thigh legs compression, stockings, and intermittent compression until they're totally mobile. We repeat the duplex at 2 and 6 weeks, and then at 3, 6, and 12 months, and then annually, unless they come in and are complaining of an issue. We do measurements of the limbs on each of their clinic visits. They're seen through the anticoagulation clinic and the thrombosis clinic to help manage their anticoagulation and maintain that they're on adequate anticoagulation and antiplatelet agents. They should have some quality of life scoring assessment and a Volta score calculated with each visit to document that we're doing something and that we're not just treating ourselves. I'd like to thank all of you for listening, and hopefully it'll be some of this beneficial. Food for thought is you always have to think of these lesions, and especially with atypical recurrent lesions and with patients that don't respond to treatment the way you expect. I'll be happy to answer any questions and look forward to the discussion.
Wow, what a magnificent presentation, Joann. Very complete, very thorough, with all the information that our viewers need, and all for that matter. And I wanna tell you, I don't know if you can see us on the screen. One friend of yours just joined us. Dr. John Bismuth made it after the traffic. Everybody was trapped in traffic, but he's here and he listened to your presentation as well.
Correct. Yeah, it was fantastic, Joann. Thanks for joining us. I was about one of the more thorough presentations I've ever seen on venous disease. So I learned a bunch. Of course, I have questions. I always do. And I think
I hope they're not too hard.
No. No, so I mean, I think it's more questions in terms of practices. You know, obviously we have in the last couple of years, we've had the new venous stents, venous specific stents that have come out, and it seems like there is just a venous frenzy these days. What do you see that actually doing over the years? You know, what are the repercussions potentially of that? Because to me is, you know, when you see that kind of frenzy, things can quickly turn sour.
Well, I kind of like I talked about when I spoke briefly about it, I think that 5 years ago, 7 years ago, industry got very interested in this, and given the prevalence of the disease and the aging population and the amount of ulcers and stasis problems we have, everybody looked at this as a gold mine. Everybody looks at veins as the stepchild of the arterial system. And we went through this when the aortic minimally invasive stuff came in. We had all kinds of graphs, we had all kinds of companies, and there'll be some starts and fails, and eventually we'll come down to understanding the pathophysiology better. Veins are not arteries. I think that the amount of inflammatory mediators on the walls with some of these post-thrombotic patients are really the key. And that's why I think maybe endophlebectomy may be a more appropriate choice, again, in the good risk surgical population with good inflow, or to establish good inflow, because if you put stents in and you don't have good inflow, they're not going to stay open, and that just compounds your problems. I do think that the iliac bifurcation at the cava is a potential problem, but there's some new stent designs looking at a body with a limb attached, and then a kind of like the aortic endografts where you put the other limb up to eliminate that gutter and to eliminate some of the turbulence that we saw with some of the kissing stent stuff that we tried early on that didn't work so well.
Yeah, I think ultimately, I think you made a great point, is it comes down to understanding the pathophysiology. And unfortunately, I think a lot of the people who are treating these today probably don't understand the pathophysiology. I don't know that I fully understand it. And then haven't had any training in it and are sort of learning on the job. I mean, we talked a little bit about it, Ulises and I, and clearly there is not in every program, whether it's vascular or other programs, IR or interventional cardiology, they don't necessarily have that training, that background in venous disease, but certainly are treating it. And so I guess what I would ask is, what is the word of caution, or what would you recommend?
Well, veins are not benign completely, and you can do harm. And so you first want to do no harm. I probably get the most phone calls from my former general surgery and vascular trainees about what to do with venous patients than anything, because, it's the intern's case. They don't do a lot of it, and they don't really consider it worthy of their training time. And yet when you get out into practice, you realize you see all these swollen limbs, all these varicose vein patients, and all this obstruction. All you have to do is look around at all the vein centers on every corner. Correct. To know that there's a lot of money being spent. Whether it's being spent appropriately is a different question. Correct. And so, again, I think that I know the American Venous Forum looked at this 15 years ago. The amount of training that our vascular surgery fellows spend doing veins was almost nothing. I'm glad with the pulmonary embolectomy teams and some of this new, more exciting things that it's becoming a little more glamorous, and they're getting more involved in the treatment of veins. But for years, venous disease was relegated to the second stepchild. And so I think the appreciation of what we can do now and what the opportunities do, this right now is an area that's exploding both from a technological standpoint and a knowledge standpoint. And so I think it's really exciting for young people to get involved on the startup of all of this. And so I would encourage people to really, if you're looking for research areas, this is a great area for research projects.
Yeah. Joann, I have a quick question and a comment. The question is, regarding collateral circulation, when you have a stenosis in an iliac vein, so let's say, and it is significant, it's more than 60%, but you do not have any collateral circulation in the venogram, what is your approach there in a symptomatic patient?
Those people are really symptomatic, and again, you'll see patients that have a complete obstruction, and you'll see collaterals on their back, on their abdominal wall, all over, and they don't have any trouble. We used to, before we had the current filters, I mean, in my initial training, I used to take an umbilical tape and tie off the cava. Sure. With Dr. Cranley years ago, and we do all the pathophysiology and the changes. But those patients, even 40 years later, if they did compression and had good collaterals, were asymptomatic and didn't have changes. The patients that get into trouble are people that do not collateralize and have obstruction. And so those people I'm more aggressive about treating. But you, again, want to look at what the goal of therapy is, what the pathophysiology of your patient is, and then you want to have established expectations for outcomes. What's reasonable for this patient to be able to do versus what they want to do. And so, they have to have reasonable expectations and goals of therapy.
Yeah. In the comment is just a brief comment regarding keep ourselves updated in all the medical information, the progress that is been going on in the pathophysiology of edema. You touch about edema, and it's so important. The revised Starling equation and all what derives from there. I see many patients that come to my clinic with edema that they are put on diuretics, like you said, and they don't improve. They stay pretty much the same. And what is the answer that some of those colleagues of mine do, they double the dose. It's like it doesn't improve with a little hammer. Let's bring a bigger hammer. I mean, it doesn't make sense, but
well,
and
then you could just put their stent in for their dialysis access.
Yeah, it is just wild. But anything else, John?
Yeah, I did have one question. So obviously we're in Houston. Obesity is a problem throughout the country. It's certainly prevalent here as well.
The Midwest is no different.
Yeah, no, I'm sure. I know Ulises and I have spoken about this before, and he always says, yeah, if they're obese, don't stent them, don't treat them. What do you feel about that? You know, and you know, should we avoid those patients? Because generally, I feel like he's right. They don't really do that well when you stent them. They may have some edema, but they don't really do super well.
Again, if they're a good risk patient, Frank Padberg did a lot of studies and a lot of work with obesity and venous insufficiency. If you can get the weight off, some of the changes are potentially reversible. And I actually, if they're young people, I actually talk to them about bariatric intervention.
Sure.
Because they've got to get their weight down. I can put a stent in and they can crush it and it'll be thrombosed, and then we've just complicated their problems.
Right.
Absolutely.
Right. Yeah.
Joann, we are so grateful that you have agreed to help us, and this lecture, as Jean mentioned, is one of the most thorough that I've seen. Very complete. We are very grateful for your help, and we would love for you to come back later on and teach us about some other stuff that you want to help us with. Thank you so much.
Thank you for the invitation and the opportunity.
Thank you. And to all our viewers, this is the last broadcast from this spring, I guess. We are going to be taking a break. We is too many people. We over there are going to be taking a break, and we are going to come back in the fall, but we'll keep you posted and when we return with the Venous and Lymphatic Forum. In the meantime, I want to thank my colleague and partner, Dr. Jean Bismuth, for coming here and helping me with this idea, with this task. And stay well, stay safe, and God bless you. Thank you, Jean.
Thank you.